Today we're going to be talking about direct payments and healthcare, and I'm extremely pleased to have with me today Gina Walton from Kent. If you want to say hi, Gina.
Hi Simon.
And also with me is Harris Patel, who's someone who's been using personal health budgets in Kent as well.
Hi, yes, I can hear you clearly.
Great. So firstly, for those of you who haven't yet caught wind of this publication, the webinar today is in part a celebration of the launch of a publication that we've recently produced for the Healthcare Financial Management Association. I know we have with us Anna Green from HFMA today. And the publication is free to download from HFMA's website and also orderable in printed copy if you wish. It's designed primarily for financial managers working within healthcare organizations who may be involved in one way or another in developing the systems and the financial controls and procedures to make healthcare direct payments possible for people as they start to be rolled out from 2014, which we believe will happen following the evaluation, which is shortly to be published. So there is a lot of experience and information that we've gathered from the personal health budgets pilots that's infused into this publication, and some of which we'll be hearing from in conversation with Gina and with Harris shortly. That tells us that direct payments work really well for people, for many people in many instances, for healthcare services and support and care needs, and that there is an expectation on CCGs that they will be a need to prepare for the wider rollout of personal health budgets and for direct payments, and that they're likely to be a commonplace way of delivering support for people for both health and social care needs in the future. It's a refrain that's picked up in the white paper, and you can see on the screen the quote there that underpins a commitment from the government to roll out personal health budgets subject to the evaluation, but there are very clear signs so far that commitment will not only be followed through, but there are likely to be a step up in the ambitions related to direct payments in particular as part of the rollout of personal health budgets. So where are we at the moment? Well, we know from all the experience of direct payments since they were first introduced for social care in 1997. So there's a great wealth of history of people using direct payments over many years, and they have proven to be a very tried and tested way of giving people choice and control over the way in which their support needs are arranged. In last year's survey, published by Think Local Act Personal, called the POET survey, Personal Outcomes Evaluation Tool, which looked at the experiences of 1,000 people using personal budgets. It was one of the very clear findings that people who took a personal budget as a direct payment had more positive outcomes than people who received a managed budget. So there's a lot of evidence and a lot of history of people using them in ways that help people to get more of their outcomes met and receive tangible benefits from using them as opposed to other methods of receiving services and support. As an agenda, direct payments have cross-party political support, have done for many years, and also underpinned by a foundation of support from disabled people's organisations who campaigned for many years for the original legislation and remain very much strong advocates and supporters and very key to the successful delivery of direct payments, particularly of direct payment support. Up until recently, people who became eligible for NHS continuing care would no longer be able to receive direct payments, and the powers that the personal health budget pilot sites have been using, those that applied for their specific powers, have extended the ability of PCTs to offer direct payments for people with continuing healthcare for the first time. And those powers are now being extended through until 2014, when legislation is expected to be making that possible for all CCGs to then be offering them as a matter of course. So there is a commitment for the government to enable everyone in receipt of continuing healthcare to have a right to ask for a personal health budget, including as a direct payment, and for that to be underpinned by legislation is the firm expectation. And in parallel with that, some of you may know there is a pilot program which the Department of Health will be kicking off shortly to test out direct payments in residential care settings. I think the position as it stands at the moment is that they've received something in the region of 20 to 30 bids and are going through those to look at which ones are going to be successful and have support to test that out. Some of the lessons that we have learned so far from work within the PHP pilots and from using direct payments over many years in social care. From the POET survey, there was very interesting and quite clear evidence that direct payments worked well for older people as well as people from all other groups. Slightly different and interesting information to what came out of the earlier Ibsen report looking at the evaluation of the individual budget pilots in 2005. The benefits that people were measured against in the POET survey looked to be pretty much equal between people over 65 and people under 65. Some of that might have been due to people having had direct payments for a much longer period of time than the Ibsen evaluation, but an interesting finding nonetheless, and clearly shows that if direct payments are delivered well, then they can work for a full range of people. Another finding, particularly from that survey and has cropped up in a lot of research about direct payments, is that the early conversations that we have with people about whether or not direct payments are appropriate, what's involved, will colour people's perceptions of them. So who's having those conversations and how the benefits and the work involved in setting up a direct payment is explained can have a significant impact on whether or not people feel confident to take them up. For the PHP pilot sites, and I'm sure this will come up shortly in conversation with Gina, many of the pilots have been using local support services successfully to provide support for people using healthcare payments in the same way as they're supporting local people to use social care direct payments. And many of the pilot sites have been focusing on trying to make sure that there is access to good peer support as part of that mix of the range of support that's available for people to take on a direct payment and use it well. One other finding that's really important to note from the POET survey is pivotally how complex the process is for getting and using a personal budget and a direct payment. It directly affects the benefits that people can get from them. So complex processes, mixed messages about what's possible and how people are able to use them can impact very significantly on whether or not people have a good experience of direct payments overall. There isn't a great deal of evidence at this point to show that people using direct payments are at any higher risk than people taking directly delivered services. And many of the sites, and again this will come up in conversation with Gina and Harris, are taking an approach to monitoring that is aims to offer some proportionality in the approach. So for low risk cases, they may take a different approach to how people's use of a direct payment is monitored than someone at a higher risk. Okay, at this point, I'm going to bring in Harris, if that's okay, to talk about your experience of using a direct payment. So I'd like to ask Harris if you could maybe tell us a little bit about, to kick off with, what your situation was before taking on a direct payment and what support needs you had that triggered those conversations about direct payments being an option for you.
Okay, no problem. Hi to everyone. Prior to being on direct payment, I basically had no control over my care package. My care charges were paid directly to the agency by KCC Kent County Council, and very often I was in hospital while I was at home but had other prior engagement, i.e. hospital appointments, and the agency was still charging for the calls they did not cover. Hence I had no control over my care costs.
Okay, thanks. do you want to say a little bit about how the process was for you, Harris? What steps did you have to go through to get you from learning about a direct payment to getting the direct payment in your bank account, or was it? I presume it might actually have been on a prepayment card. Was it when you?
I had back in 2006. I had a care manager who actually came to review my case, and whilst he was reviewing my case, he actually mentioned about the Kent card and the criteria that would have to be fitted, which was for disabled people of all ages, parents or disabled children for meet their children's needs, people with parental responsibility for a disabled child, and so and obviously care of the age 16 and over. Yes, so I was mentioning about the Kent card. The Kent card is a new, secure and convenient way of receiving my direct payment for community support and assistance. It was an easy way to pay for my support. It is a chip and pin Visa card which does not need a bank account. You can use it to pay for my support in the same way as using a Visa debit card. Ideal for people who cannot have a separate bank account.
Okay, thanks, Harris. Can you say a little bit about what the process was like for you? Was it did it take a very long time? Was it quite quick?
No,
and a little bit maybe about the planning that you did to
okay,
work out how you were going to use the direct payment.
Okay, the planning process was quite simple. My care manager and myself drew up a care plan, and in the care plan, my shopping calls, domestic and social outing calls were included, along with my daily personal hygiene calls. Once we agreed what my needs were, my care manager drew up a contract regarding as to how I will use the funding, and once the contract was signed, for the following month I was receiving direct payment, but at the same time I was a bit unhappy using the Kent card for personal reasons, so I decided to have my direct payment paid into a bank account using a checkbook to make payments. I had to set up a separate bank account for the direct payments. Basically the payment actually went straight into my bank account, and as soon as I received an invoice from my agency, I just raised the check, and it was that simple.
Okay, that's really interesting. Thank you. So you moved from initially using the Kent card to then setting up your own bank account and having your money paid into that account. Yeah?
Yeah, into a separate bank account from my personal bank account.
Okay. Thank you. Can you say a little bit about how you're using the direct payments now, and how things have changed for you from how things were before you started?
Okay. Many things have changed since I was getting direct payments. In 2009, I was assessed by continual NHS healthcare team, and they found my health was in a poor condition, so they arranged for continual NHS healthcare nurse to come and do a full assessment, and after the assessment, she said that I would qualify to move from social care to NHS funded nursing care, which is called continual NHS healthcare, where my care package will be fully funded by NHS healthcare. When I was moved from social care to continual NHS healthcare, the local PCT were paying the invoice, and again I was not very happy as I was not in control over my care package. So I spoke to the community matron, and she said she will look into the matter, and that is when Georgina was involved with my care package. Georgina and Mandy Smith made an appointment to come and see me and do an assessment and discuss the options regarding direct payment paid into my bank account. At that time, there was a pilot scheme in place which is called Personal Healthcare personal health budget. I've been on the personal health budget since 2009, and I use my personal budget for my everyday use, like for the paying for the care, for my domestic calls, for my social calls, and I pay for my respite care as well.
Mm-hmm. Okay, thank you very much for that, Harris. If it's okay, I'd like now to turn to you, Gina. I wondered if you could perhaps start by giving us a little bit of an overview of what work has gone on in relation to personal health budgets and direct payments in Kent and Medway.
Yes, certainly. So I'm employed by Kent County Council, and I was lead for the Kent card. And then when Personal Health Budget Pilot was launched by the Department of Health, I was informally seconded over to NHS Eastern and Coastal Kent to lead on personal health budgets. And we looked at a number of areas to test a budget. Maternity, and we were the only site in England to look at how personal health budget would work within antenatal and postnatal support. Mental health, psychological therapy, step 3, so that's face-to-face intervention. Continuing healthcare, and for us continuing healthcare was the area that we really wanted to test the personal health budget because of people that would move from social care funding who would have had possibly a direct payment, employing their own staff. Traditionally, when they moved over to continuing healthcare, that package would have stopped because health did not have the powers to make direct payments and they didn't have the systems to do that. So for us, that was an area that we really wanted to test to try and create that seamless transition from social care funding into health, but also for people that will go from health funding if they improve back into social care. And then we did also do a small pilot with end-of-life care, but unfortunately we only did it with a small number of people. It was around having processes in place that were quick and responsive and getting that package and direct payment set up very quickly so that somebody would have the opportunity to use that budget. In order to push forward with the pilot, we worked in partnership with Kent County Council and used the local authority payment system, the direct payment system, to make payments to people that wanted to receive a direct payment using the Kent card, the preloaded card program, but also loading into private bank accounts if somebody chose to receive their direct payment in their bank account. And also we looked at all of the policies and processes that were in place. So we didn't go off and redesign. We utilised what was available so that we didn't duplicate systems. And that meant we could get the pilot up and running quite quickly. We did use the framework of the Section 75 agreement to allow the NHS to use the systems within the local authority, and that's really just to safeguard Kent County Council financially because of the large amount of direct payments that were being paid out to people under continuing health care. But that was quite quick to get set up initially.
Okay, that sounds really interesting. Can you tell us a little bit about the development of the processes to make that possible? How long it took and how that partnership kind of worked in order to kind of develop something that was kind of practical and possible to make the delivery of direct payments an option?
Yeah, well, what we did when we first started the pilot, we brought together all the key stakeholders. So that was partners from the local authority and the NHS, but also people that use direct payments within social care. And we mapped out the process to look at what was working. We also looked at what didn't work around the implementation of self-directed support, some of the things that didn't work so well, so we could use those lessons to help with setting up personal health budgets. But we mapped out the process for direct payments, looking at things like direct payment agreement that is in place, what support people would need when they take a direct payment, the policy that is in place within the local authority around employing personal assistants, how the local authority managed the finance reviews. And Simon, you referred to this earlier around how we have this matrix approach. Within Kent, we we do a matrix when somebody takes a direct payment, and it's based on risk. So we have low level, medium and high, and depending on the level, the size of the direct payment and the number of people that somebody may employ, would then put them into a certain risk category, and that would determine the frequency in which they would have a financial review. So somebody who is a high risk would have a financial review every 3 months, medium risk would be every 6 months, and high risk low risk would be annually. But with the Kent card, the preloaded card program, that has streamlined our back office systems and made it a lot easier to manage the financial reviews, and we can do those as a desktop exercise because we can get the bank statement sent to us online. So that reduces the bureaucracy for the person that wants to receive the direct payment, because they're then not getting caught up with lots of paperwork, but also makes it a lot easier for the staff within the health and the social care system, because they can do a lighter touch finance review but support people as and when they need it. The biggest thing around direct payments for us was around that support, helping somebody decide how they want to receive that direct payment, would they want it in a bank account or a Kent card, and helping them set that up. But then also how they would manage the direct payment, and if they're going to employ, they're going to use a payroll system, supporting them with setting up all the tax and insurance, and doing that support planning process, looking at how the budget would be broken down. For personal health budgets, we had a healthcare navigator in post, who is employed by a volunteer agency within the volunteer centre within the Kent area, and we used in-depth pilot site funding to grant that provider so that the broker could work with individuals who were taking a personal health budget, and she would then work with them to think about how they wanted to use that budget, but also give them that direct payment support. And she would then be the key link ongoing to provide any support. So if the person wants to change the package, she would give that support, but also do that financial monitoring.
Did the healthcare navigator, Gina, link in with existing direct payment support services, or was that housed kind of separately? What was the relationship between what existed before and this new role?
Yes, well, within Kent County Council, we have an in-house service. We call them now personalisation coordinators, but they were employment support workers, and we have those aligned to each locality within the council. And they would traditionally help people set up the direct payment and give them that support around employment and do the financial monitoring. The broker linked in with that team, and still does. She would go to their team meetings so that we can ensure that we share good practice, keep each other informed of progress. Because the things we've learned around the implementation of personal health budgets that's been shared with the local authority, things as simple as we went away and wrote a new direct payment agreement for healthcare budgets for direct payments. But actually what we probably should have done was developed and built upon the existing direct payment agreement that was used within the local authority, and not go off and rewrite a new agreement, so that someone like Harris, who moved from social care funding into health, could have taken that agreement with him without then having to sign a whole new contract. And that's what we're trying to look at doing at the moment to ensure that we do have that seamless transition. We're working with health to ensure that the support plan developed within social care captures the level of detail that health would want to see in order to sign off, so that somebody could take their social care support plan with them into health. Health could look at the plan and agree to it, and agree the funding and the direct payment. And then what we would do behind the scenes is just change the budget code, so that for the individual they go on this seamless journey and just carry on accessing the package of care that they had in place. But behind the scene we just changed the funding stream going into the direct payment and making it a lot easier for them. So we are trying to work together to create, share good practice and not duplicate those systems.
That's really interesting, and I'm sure it's going to generate a lot of debate from what we've heard from yourself and from Harris so far. I'm just going to ask a couple of interrelated questions to finish off, and then we'll open it up for questions from everyone who's listening in. I wonder if you could say just something about how you're monitoring whether or not you think people are getting better outcomes, and if you're collecting information about that, and also if you're collecting information about how people are spending the money, and if it looks like, so it's like 3 questions, but it's meant to be all related, if it looks like they're as cost effective or more cost effective or not than traditional services.
Okay, well I'll start and then I'll bring Harris into it to share his experience. In terms of the cost, the direct payment given to individuals receiving a personal health budget, we've set the cost at the traditional cost of what it would have been for the NHS to deliver that care, so it hasn't cost more. In terms of the potential to reduce the budget, that will be coming out through the evaluation which will come out next month. There are cases where by using a direct payment, employing their own PAs is slightly cheaper than using an agency. In terms of outcomes, and I'm sure Harris will share his experience, the feedback from individuals having a direct payment has been very positive around the fact that they can maintain that control. Certainly for those that have gone from social care into health, before we would have had a number of complaints where people were very frustrated and upset around losing their personal assistants that they'd spent quite some time with when they were going from social care funds into health. Yeah. And for many of them, it's been quite a positive experience being able to do that. The evaluation will also pick up on outcomes, and if by having personal health budgets has improved individuals' health and well-being, but also had an impact on GP and hospital admissions. But the feedback we have had has been positive. Harris, would you like to share how you feel that having a direct payment has been your experience?
Yeah, sure. Personally for myself, the personal health budget has worked very well for me. For a simple reason, I found it very useful. When I'm reviewed on a 3-monthly basis, and if things have changed for me, the reviewing team, i.e. the nurse, would actually assess my needs. If they're greater, then she would amend and make the funds available for that particular service that I would require to improve the quality of my health and life. So that is a plus for me. Plus, by having somebody reviewing my case on a regular basis, it sort of makes me feel safe that somebody actually does look at my disability and my needs.
And I'd just like to add one last thing around monitoring the outcomes and how we measure that. We've used a number of tools within Kent. We've used the recovery staff, people that we use in a personal health budget for mental health, where they would map at the beginning of the process how they were feeling, and then once they'd finished accessing services, how they felt. But also the Poet tool that you've already referred to, Simon.
Yeah. That's really interesting. Thank you both very much. I'm going to now open it up to questions from the virtual floor. Kerry, can you tell us if we have any questions? I think you'll probably will see them and I might not.
Okay, thank you. We don't have any questions on the board at the moment, so if anybody would like to ask a question, you'll see on your screen there is a section that's called questions, and you can type into the questions box. Once you've done that, I can then read them out, and Simon, Gina or Harris can then answer your questions for you. So we'll just give you a minute or two to perhaps type in any questions that you might have, and we'll let you do that and come back to you in one moment.
Brilliant.
Simon, can I just add something?
Of course.
Right. What would I say to people thinking of taking up their personal health budget or direct payments? Can I just say that direct payments can be made available to anyone who needs healthcare and could benefit, and anyone who needs NHS aftercare service and meet other criteria covered by social or healthcare organisations. A person must be also be able to manage direct payments on their own or with assistance. Be prepared for regular reviews from social or healthcare team. I think that's important, that people should know that everybody is entitled to direct payments.
Thank you, Harris. Can I ask you, whilst we're waiting for questions to come in, a similar question about what you might want to say to people who are involved in setting up in a way that Gina is, for instance, setting up and running the systems and processes to make direct payments available and an option for people. What would you say would be important to bear in mind, the things that make a difference in relation to the process for you?
Okay, I think the most important thing is the assessment process should be a single assessment process. That's a must. The other thing I would say, they should educate healthcare staff, including nurses, physios, occupational therapists, local GPs, consultants, and anybody directly involved with people like myself who promote the service in their houses. There should be point of sale materials at all public shared places should be covered by anywhere where they have a media information service. We in Kent are very lucky as we have a very good PhD team who put themselves out in promoting direct payments and other services that go along with direct payments. I personally am very happy with the personal healthcare budget direct payments, as it gives me complete control of my care package and as to how I want to spend my funding, and it gives me so much independence.
That's great. Thank you very much for that.
Can I add as well, Simon, not to make the process bureaucratic and to just give it a go, even if it's with a small number of people, just to explore and test the potential direct payments within healthcare. Just give it a go. The other thing is, do not underestimate the engagement of frontline staff, because they're the ones that will make or break this and can make direct payments work. If they really understand it, they can give that support and raise the profile of direct payments and give support to individuals that wish to take one. If we don't engage frontline staff and really get them on board with understanding the concept of how direct payments work, then people will not feel so inclined to take them, because it may be one of those things that is described and explained to someone, but it can sound quite complex. And actually, if we have quite simple processes in place, it's not as complex as it needs to be. It can be a lot more straightforward.
No, that's really helpful. Thank you, Gina. I wonder if some of the approaches that you've tried, presumably in the pilot phase, will have been things that you can make happen for small numbers. And I'm wondering what you see the challenges are in scaling up from where you're at now to making this an option which is kind of more mainstream.
Yeah, well, within continuing healthcare, that was an easy area to start with for personal health budgets, because we've always given it's been calculated case on case with continuing healthcare, but with conditions such as long-term conditions and mental health, a lot of the money is tied up with block contracts with the community providers. And that's one of the challenges for health at the moment, is starting to unpick those block contracts so the money can be freed up from the system in order to give as a direct payment. And just looking at how that system works and managing that market in terms of providers being available to deliver the support services and care that people will be looking for. We did find within the personal health budget pilot that providers were very positive, and that there was a lot of choice out there for people. There was always a concern that, yes, you can give people the money and they can go off and make those choices, but the providers may not be there. Well, there certainly was the providers there, but it was just about giving people that right level of support to be able to make those informed choices. And having systems in place such as third-party provider, we set up a third-party option with a voluntary organisation who would manage it's still classed as a direct payment, but they would manage they would hold the direct payment on behalf of the individual for people that either felt that they couldn't manage it themselves or who lacked the capacity to make that choice, but the family felt that it was still within their best interest to have a direct payment because it would give them that flexibility. So it's about looking at the systems that are in place and commissioning those services to make it easier for people.
So would you say that you've had a relatively positive response from local providers, and have there been some that have adapted their offer for people who are using healthcare direct payments?
Yeah, I think with direct payments, it's always interesting within social care that we found, Harris referred to this earlier, that people are in control of that money. They can see how much their care costs, and they're in control of those invoices coming through, and they would question charges that a provider may have put on the invoice for services that they hadn't received. And we found that it's the same within healthcare. People that have a direct payment are saying, well, hold on, I haven't had this service. You didn't come and deliver this 15-minute call. I'm not going to pay for this. But also, providers have looked at the way that they've delivered their services and looking to make them more personalised. I know that our community provider has worked with us to deliver personal health budgets. Although they are under the block contract, they're thinking about their business model for the future, but also took the opportunity to learn from personal health budgets to look at what people were asking for and help them redesign their own service.
Oh, that's really interesting. Thank you. And if I may, I just also wanted to ask something about the Kent card. The Kent card has been in use for some time for people, as far as I understand it. It's social care direct payments. I wonder how the take-up of the Kent card is going. If it's a popular option for people with healthcare needs, and also maybe if you could tell us a little bit about the way in which people can use the cards to buy different things, if there are any restrictions on that, because I'm mindful that some prepayment cards work in different ways. Some are more restrictive than others, and it'd be interesting to hear what your experience has been in Kent and how that works.
Well, Kent County Council's had the prepaid card now for 5 years. We set it up in partnership with the Royal Bank of Scotland, and we've allowed the NHS Kent and Medway to use the card to make direct payments to people. And what we've found is that we still offer choice between a prepaid card and a bank account. Within social care, we've probably got about 60% of people now receiving their direct payment via the prepaid card. And that's just because they find it a lot easier to receive the payment. It's quicker to set up. It's just, we can do the application form for them. It means they don't have to go to a bank and show ID. For some people, that in itself was a challenge, having the ID to set up a bank account. And having a poor credit history would also restrict them from having a bank account. And we found that there's a number of people within the personal health budgets have also wanted to receive the Kent card just to make it easier for themselves. It restricts the amount of paperwork they have to hold, because we can do desktop finance reviews, so we don't require this shoebox of information to do a financial audit to check where they've used their direct payment, which would normally have included a bank statement and receipts. The prepaid card works very much in the same way as a Visa debit card, where you can use it face-to-face via chip and pin, you can use it over the telephone, but also to make online payments. And most people will use the prepaid card to pay via the telephone. They'll receive their invoice from a provider, and then they would phone up and just give the card details, and that the payment is then processed. The card does give us some. The card does come with some key features. We can restrict the use of the card in certain merchant categories. We tend not to apply that unless there's an agreement between ourselves and the card holder, because it is their card in their name. Sometimes they will ask us to restrict certain merchant categories, so that could be retail, so they couldn't use the card within a Tesco's or a supermarket. We can also block cash, but again, that's all done in agreement with the card holder. The reason cash is blocked because cash can be quite hard to evidence where it's been used, and it doesn't always have that audit trail where a card payment will. You could see a bank statement and see where the payments have been used, which makes it easy for us to do a desktop finance review. But we don't apply those restrictions because, as I say, it is about promoting choice and control, and we would do that in agreement with the card holder. But it has streamlined our systems. It's meant that we can do lighter touch finance reviews, and we can also use the information to inform our own commissioning within the local authority. If people are using the direct payment to go to a certain provider, or should we be looking at that within our commissioning if people are choosing certain providers to use? That does help us.
That's interesting. So it sounds like there is quite a high take-up from people, but also that if people from Harris' experience don't find it fits their particular circumstance, they can also move from one to the other. So it's not a kind of a one-size-fits-all. It's an option for people.
Absolutely, we allow choice, and what we're looking at the moment, Simon, is how we can do integrated budgets. We've done a small pilot with 3 people, but we're now looking to do a larger number, a larger cohort, where what we're trying to do is bring the budgets together, and we're using the Kent card as the key tool in that if somebody wants to have a direct payment. We will offer the Kent card, but also a bank account, so they can make that choice. But with the integrated budgets, what we've been doing is this dual carriageway system where we'll use our health systems to calculate a budget for somebody, and we'll use the local authority systems to calculate a budget and also do the financial means testing. And then we'll bring the 2 budgets together once it gets to the individual. So they'll be communicated one budget. They can do one plan around how they'll use that budget to meet both their health and social care needs. And then that direct payment, the 3 people we had on the pilot, 2 of them wanted to have it as a direct payment, would then be loaded either onto the bank account or Kent card, and then we'd use that to access the services. And what we've agreed within this pilot is that we would have one person monitoring it from either the local authority or the NHS in terms of how the direct payment's being used. So we're not having this bureaucratic system of different people going in to do different parts of the process. Okay, that's health money, that's social care money. We just want one person to go in and work with the budget holder and do that monitoring with them.
Yeah. That's really interesting. There's a paper just recently issued by the NHS Confederation on a very short paper on joint personal budgets, looking at one of the questions it poses is whether or not joint personal budgets are the answer to integration, and whether or not this what they describe, and I think it's a term that you use as well, as a dual carriageway approach to the processes involved of getting people a joint integrated budget, where it's the focus is on it being seamless for the individual, but there are parallel processes in train. Whether or not that's scalable and can work for as a mainstream way of delivering joint budgets. Do you have a view on that? Do you think that's a reasonable way forward?
It was a way for us to test integrated budgets, and it's a way we're going to continue to do integrated budgets until we can integrate our systems. Because in order to do true integration, we're going to have to look at IT systems, bringing our teams together, which we are looking at under a health and social care integration program. But that is quite a lot of work, and what we didn't want to do was hold back from doing integrated budgets whilst we did all of that other work. So we felt that a dual carriageway system was a good way to test an integrated budget. As you say, it's quite seamless to the individual. We will have that dual carriageway system behind the scenes, but once it gets to the level of the individual, they they will really benefit from an integrated budget. But with the lessons from that we can use to develop a strategy to make it more sustainable for the future. And really I see integrated budgets as a key tool in health and social care integration.
That's really fascinating. Thank you very much for that. I think we're more or less out of time, so I'll have to call it to a close there.
We don't have to stop at 3 if you wish to continue. I do have 10 questions that have been asked if you'd like to do them.
Oh, do you? Okay.
Oh,
I'm sorry, I
excellent.
didn't realise that the questions had come in.
Do you want me to read them out?
Please do.
So the first question is from Heather, and Heather's question is there any experience of this service for under 18s?
I'd say with the work that we've been doing with the Department of Health, looking at supporting the sites who have been working on integration, of which Kent was one, I think there's been a small amount of experience for people using budgets for both health and education related support. And some of the most vocal and interesting kind of stories to come out of the peer network that's been working alongside this program have come from people using budgets for those means, and some very powerful and interesting stories that I hope will find their way into one part of the toolkit that's due out very shortly. But it is an area I think that that there will be a lot of developments in the future. We recently met with DFE as a Groundswell partnership to talk about the work they're doing on the SEN program, and looking at the parallels with personalisation and the potential for growth of personal budgets. So broadly, I think it's a growth area. Our particular kind of exposure to it has been relatively limited, but the stories have been very powerful and positive. Gina, do you want to say anything from your perspective?
Well, we didn't pilot budgets with under 18s, personal health budgets. We are looking at it at the moment in the local authority around how we can support better transition, because that's an area that we want to look at. But I do know we're also looking at the SEN pilot for bringing together health, social care and education budgets, so that's something we are looking at the moment.
Okay. Okay, should we move on to the next question, Kerry? I'm mindful that the slides are taking on a life of their own again, so apologies for that.
The next question is from Janet. It's quite a similar question-ish to Heather's. Will this be available for children's services on DP?
Mm-hmm.
I forgot to add to my previous question, answer, was that we have actually looked at direct payments for continuing healthcare for under 18s. So there are options. It's around getting the powers from the Department of Health to do that, but it's certainly an option that can be looked at.
Okay, should we move on to another question?
Yeah, next one is from Mary. Mary asks, were there challenges bringing LA and NHS thinking together, for example, CRBs for PAs or not, risk enablement versus risk management?
Well, within Kent we have a positive. In Kent we have a positive risk management tool within the local authority to encourage practitioners, case management staff to think more positively around how somebody will take some, not risk, but how they would manage making that choice and control, and taking choices that may be outside of traditional thinking. In order to help health colleagues, we all came together to share those policies and processes, and we held a number of workshops to challenge each other and think through how positive risk management works. And things like CRB, what we've done for personal health budgets is we mirrored the policies that we had in place within the local authority. So we didn't have to go off and redesign any process. We just looked at what was available and took what we used within the local authority and, as I say, mirrored those processes.
Okay, the next question is from Sarah, and the question is the NHS paying a fee to the local authority to provide direct payments for CHC patients?
What the NHS has agreed is to cover a part-time finance post so that we are not having to use our resources within the local authority, which are already focusing on doing their own day-to-day work. So they have agreed to fund the financial post, which is part-time, because it doesn't take more than the part-time post to do that at present with the number. And I think some people might say, well, is that then increasing the cost in terms of the direct payment support system? Some of the benefits that we've seen around doing this is that you would thereby giving people that direct payment. An example was that we had a number of people that would phone up on a Friday afternoon requiring emergency respite to the NHS continuing healthcare team, and then they would spend that afternoon looking at very reactive commissioning and trying to put in place an emergency package or trying to find something that was suitable. Whereas with this, we found that by people taking that control, you've cut those, not all of them, because there's still people that are having those traditional packages, but you have cut those telephone calls down and that contact.
Okay, the next question is from Hilary. Have there been any examples of family carers being supported with a health personal budget and being employed directly to support the person?
Well, in Kent, we have mirrored and it is within the policy, the Department of Health direct payment guidelines is around somebody who lives in the same household, and we have used that policy, and we do use that somebody within the same household can't have the direct payment unless there's an exceptional reason to why they need to, and that would be agreed by the budget holder family and also the practitioner involved, that it is a good reason to why that person needs to be employed. But outside of the family home, relatives, carers have been employed to deliver the care and support.
Okay, the next question is from Dawn. Who reviews and monitors the personal health budget, especially for NHS CHC, as we find that there is often a high input of time, or with personal health budgets, have you found that this has meant less of a need for monitoring, and then she's put in brackets, review obviously within the risk matrix, however?
Well, in terms of the reviews are still done by the continuing healthcare nurse assessors. They still do their reviews that they would normally do. But alongside that, we would then do the financial reviews in terms of how the direct payment's being used and if it's being used as agreed within the plan. And that, at the moment, is being done by the healthcare broker. But what we're trying to do is look at using the workforce also available within the local authority to do some support as well. So we're trying to create a mixed model in terms of who would then support somebody, because if somebody's gone from social care into health, they would have had the support from the local authority employment support system. So it makes sense that they carry on accessing that support because they know that person, or if it's done via a Kent card, we can do the light touch reviews.
Okay, I have another 2 questions from Dawn, so I'll follow straight on with Dawn's questions. We are interested, would Kent be willing to share their streamlined processes?
Yes. I'm happy. I don't know how to do it. If we can maybe exchange telephone numbers and email addresses and then have a separate telephone conversation.
I could pass on Dawn's email address to you, Gina,
Yep.
And then you could obviously get in contact.
Yep, that would be great, and I'll send
Dawn.
her an email and then we can pick it up from there.
Okay, lovely. Dawn's last question is, can you say anything about integrated support planning and review? Does this work?
Oh, we're working on that one as we speak. We've got a health and social care integration program, which is looking at integrating teams and integrating our processes such as the assessment and the review. So that's something we're looking at the moment.
Okay. The next
Just
question is from
a quick
Laura.
one to add to that. We've been doing some work with, as I said, the sites within the PHP pilot community that we're working on, specifically integration. And there's a couple of papers that will be published as part of the toolkit that you might find helpful that should be coming out in the next couple of weeks. One is looking at what we've learned so far from those sites that have been working on this about how to join up the processes for integrated budgets, and there are examples of template integrated plans and sign-off processes and various other things there. And there's also a kind of a myth buster which looks at some of the common kind of misconceptions, if you like, that get in the way of making progress quickly, that also addresses some of the things that people might think could be barriers, but actually there are positive kind of and quick routes to kind of through. So do look out for those. I'll be on the personal health budgets pilot site very shortly.
Okay, the next question is from Laura, and Laura's question is, in terms of engagement with frontline staff, how have you found nurses, stroke health staff, etc., with regards to responding to it?
Well, within Kent, certainly the continuing healthcare team have been really positive about this, because they were the ones that were faced with people that were very frustrated and angry about the process, having gone from social care funding and being in control over into health and having a traditional package of care and support put in place. So they have really supported this and have been involved with looking at how the process works. It's now around engaging and working with other health professionals such as GPs, because they're the ones that will be taking this agenda forward, and other health professionals that were not involved in the pilot. But the continuing healthcare team have been really positive. But what we've tried to do is bring together afternoons where we've brought together health and social care staff who can work through case studies together and challenge each other and share good practice, and also for health colleagues to learn from social care around how we've done this, because we've been doing direct payments for a long time. There's some good stuff there already that can be shared.
Lovely, thank you. And
just to add to that, Gina, I mean, it strikes me that one of the points you made when you were talking earlier was that you made some proactive efforts very early on to bring people on board with how this is going to work, and that there was a focus there on doing that inclusively and on working with staff. I wonder if you think that was that made a difference, if that was particularly important and useful.
Yeah, absolutely. I think it's really important to engage the right people at the right time, and for me it's around getting that buy-in at the beginning, and for people that really know the business to come and say this isn't working and this is what we need to do, and for them to have that opportunity to voice their concerns, but also be involved in shaping those processes so that they feel that they can take some ownership of those processes moving forward. And it's around that, them not feeling like they're being done to, and that they have got that opportunity to be involved and make a success of it.
Okay, thank you. The final question is from Hilary, and Hilary's question is, please can you tell us when health personal budgets will be mainstreamed, and when can we access the report?
Simon?
Well, I don't have any information about when the report is actually going to see the light of day, but it was due out in October, so we should be seeing it very shortly. We've been told to expect it imminently, and there's no sign, as we said earlier, that the messages are going to change. As far as we know, the likelihood is that legislation will be brought in to make it possible to extend direct payments, and there is a pre-existing commitment for that to be happening for people with continuing healthcare needs from 2014. So we think it's likely to be more ambitious than that, but that's already a fair certainty, and the initial signs from what's likely to come out in the evaluation are that although there may be quite a lot of work to do to set up processes that are going to be sustainable and work in a more mainstream way, that there are things that people can do practically, and the messages are likely to be that the name of the game now is to start preparing There is also some work with a smaller number of pilot sites, I think 9 in total. Gina can correct me if I've got that wrong, called Going Further Faster sites that are going to be working over the next 9 months, I think, to try and make additional progress and look at some key issues around sustainability and scaling up for making PHPs and direct payments work in different areas.
Lovely, thank you. That's all of the questions.
Okay, well, thank you to everyone very much for joining us and for taking part. Apologies if we didn't get to the questions quite early enough, but I'm glad that we managed to get through them all. A particular thanks to Gina Harris and for giving your expertise and input into the session today and for sharing your stories with us, and to Kerry for managing it all and helping us get through it relatively smoothly. You will have seen probably flashing up at various intervals uncontrollably a slide that you may be able to see now that details our next couple of webinars. On the 28th of November, which is a Tuesday, Sam Bennett will be talking about individual service funds, and again on the 18th of December, Sam will be talking about the work that he's been doing for Think Like That Personal to develop the market relations protocol. There are also a number of webinars on the topic broadly of personal health budgets from HSA and also from InControl. So if you're interested in getting further information and getting involved in those, then please do check out their websites. As I said, this session will be recorded. If you want to share this with anyone who hasn't managed to join us today, then please do feel free. And that should be up on our website within the next week or so, and we can email you details of that. So thank you very much. I hope you found it interesting.
Thank you.
Thanks very much.